Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. As fall approaches and schools and business offices begin to reopen, the potential for near-term normalcy amid the COVID-19 pandemic feels uncertain. Today's briefing will address the latest news and research on COVID-19 booster shots, breakthrough infections, vaccine and mask mandates, variants, and how COVID might intersect with the upcoming flu season. Bloomberg School faculty members will discuss what these developments and President Biden's recently announced COVID-19 action plan could mean for our ability to try to control the spread of COVID-19 and what's needed to move forward for public health. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. First, I'd like to briefly introduce our two speakers. Dr. Anna Durbin is trained in internal medicine and infectious diseases and studies experimental vaccines for SARS-CoV-2, dengue, West Nile, Zika, malaria, and more in human clinical trials and in controlled human infection studies. She is currently the site PI at Johns Hopkins for the AstraZeneca COVID-19 vaccine. Other trials have included vaccines against HIV, hepatitis C, human papillomavirus, influenza, rotavirus, respiratory syncytial virus, dengue virus, and malaria. Dr. Daniel Selman is the director of the Institute for Vaccine Safety and a professor in the Department of International Health at the Bloomberg School of Public Health. His primary research and practice interest is optimizing the prevention of childhood infectious diseases through the use of vaccines. More broadly, he focuses on vaccine safety, policy, implementation, and addressing vaccine hesitancy, including around H1N1, COVID-19, and other viruses. We will have time for questions following our panelists' remarks. The procedure will be as follows. We will take some questions that have been submitted in advance of the briefing and some questions from the Zoom chat. If you have a question during the briefing, you can enter it in the Zoom chat addressed to all panelists. Please enter your name, media outlet, and question. We hope to cover as many as possible. Just a note that participants will be muted during this briefing and it will be recorded. Dr. Durbin, please go ahead.
Thank you very much, Ellen, and welcome. I want to start by saying that data on the need for booster shots is still coming in. At this point, it's still most important for everyone here in the United States and in the world to get their first full vaccination, whether that's a 1-dose or a 2-dose vaccine. It's important to note we will not stop the Delta variant. We will not stop COVID until the world is vaccinated. What really is going to control the Delta variant is vaccinating the unvaccinated, not boosters. And I think it's really important to note that the Biden administration's on vaccine mandates will hopefully help with getting more unvaccinated people vaccinated. Yes, the data are showing that we are seeing breakthrough infections. These infections are, for the most part, mild to moderate in severity. This means you may have a fever, feel achy, feel tired, but you won't develop shortness of breath, need to go to the hospital, or end up on a ventilator. The COVID vaccines continue to be shown to be highly effective in preventing hospitalizations, severe infections, and deaths among the vaccinated. Numerous studies have found that the vaccines provide protection against hospitalization that continues to range around 90 to 95%, even in the face of the Delta variant. We do have data coming in, and this may vary by age group, but the vaccines continue to look extremely effective. It is important to remember that COVID vaccines may not work as well over time in preventing mild illnesses among those vaccinated, but this isn't a sign that the vaccines are failing. Your immunity doesn't stop at 6 months or 8 months. You continue to be provided protection against COVID. Vaccines are designed to prevent serious illness, not to prevent infection or prevent any symptoms. And again, I want to say that I think that the Biden administration's mandate will hopefully help more people get vaccinated. Thank you, and I'd like to move on to Dr. Selman.
Dr. Salmon, please go ahead.
Well, thank you, Dr. Durbin. Thank you, Ellen. It's a really critical moment we're at right now with the pandemic. I mean, we see cases resurging, we see a preponderance of the Delta variant, and at the same time, we have very effective and very safe vaccines available. So we have the tools we need. What we need to do to control the pandemic, to get back to normal social, economic life, to prevent further unnecessary morbidity and mortality, is we need high vaccine coverage. We need people to get vaccinated, and we need it homogeneously across the population. It's not going to work if some states have high coverage and some states have low coverage, or some age groups or communities. We need widespread acceptance of the vaccine. And what we've seen throughout this pandemic is that politics have impacted our response, and many people are less trusting. And we see the vaccines have been polarized by politics, and people are getting vaccinated. More people are getting vaccinated. Vaccine coverage continues to go up, but we also see a hardening of views. And that's really challenging because the role for information diminishes as people make up their mind. It's much more impactful to impact people's attitudes and beliefs as they're forming their intentions than it is to change their mind. So there's still a role for communication. We need the right messages from the right messenger to the right people. But we also have to think about other policy levers that are available to increase vaccine uptake. And we saw President Biden come out earlier, I guess this week, with very strong policy approaches, some that are not typically used in the vaccine world, from requiring large employers to either require vaccination or testing. So we've seen, for example, a long history of school vaccine mandates that have been very effective in controlling outbreaks and raising vaccine coverage and reducing equities in vaccine coverage and disease prevalence. And we've had a history of them working. We see them in college and universities and workplace environments such as healthcare systems, many of which have been requiring flu vaccine for a long time. But we're going to another level here. I think we saw some frustration from the president that not more people are getting vaccinated. I think that frustration is held by many in the medical public health community and much of the public. And he expressed a willingness and showed that he's willing to do things that haven't typically been done. And perhaps that's necessary. I mean, we need to get vaccine coverage up. We have very safe, very effective vaccines. And we have to be pragmatic because we run the risk of further polarizing people and the potential that it could adversely impact other vaccine programs, such as the routine childhood and adolescent vaccine programs that have worked really well in this country. So we're at this critical moment in time. We need to get this right. We have the tools, and we need to effectively use those tools.
Thank you, Dr. Salmon. Now we will take questions. And a reminder, if you have a question, please enter it in the Zoom chat with your name, media outlet, question, and to whom you'd like to address your question. To start, here are two questions from Arthur Allen at Kaiser Health News for Dr. Salmon. You and other scholars have been cautious about vaccine mandates in the past. Are you concerned about a backlash from recent federal and state efforts to crack down on hesitancy? In general, can you describe whether and how the COVID vaccination experience has affected your views toward mandates and exemptions in general?
So thank you. That's a great question. And I have for a long time argued that we need to use mandates cautiously and appropriately. And there's a bunch of principles that apply. For one, from an ethical standpoint and a pragmatic standpoint, we want to use the least restrictive means possible. So we shouldn't just be starting with a mandate. And there's a lot of things you need for a mandate to work. You need adequate supply of the vaccine. Cost has to be removed as a barrier. For COVID vaccine, that's really the case at this point. We also need good safety data and good data to support the use of the vaccine, which we also have. I think where we run into problems is already having widespread support for the vaccine among the public and among clinicians is critical. And in this case, as we've started to talk about, we have roughly a quarter of the population that does not want to get vaccinated. So I think that's where we need to be cautious. I think that it's well justified from a scientific standpoint. Mandates have a long history of being effective and strong support from a legal perspective. And I think where we still need to be cautious is that pragmatically that it does more good than harm. And we have to be careful not to polarize or further polarize an already polarized environment.
And a follow-up to that for you, Dr. Salmon, do you worry that the polarized position taken by many GOP governors could end up leading to loosening of exemption standards or other trends that could threaten the high rates of childhood vaccination?
Well, I do worry about that. I worry about that because it's a potential risk to the approach that we're taking. And you ask about Republican governors, and I wouldn't be specific to them. I think that taking a stronger approach in vaccine requirements does run risk that it can polarize people. And we're already in a very polarized environment, and it has the potential to flow over to other public health measures and to childhood vaccines. So I think that that's something we need to look out for and try to think of ways to mitigate that risk.
Thank you. Here are two questions from Felicia Schwartz at the Wall Street Journal for Dr. Durbin. When will Delta-specific vaccines be necessary? For Dr. Durbin.
So thank you. So I am not sure that Delta-specific vaccines will be necessary. We know that the current vaccine works very well against the Delta variant. They've done different studies with the antibodies that are raised post-vaccination with the original vaccines, and they work very well against the Delta variant. The most important thing, again, that I want to stress is that if we want to stop Delta, we need to get more people vaccinated. That is the best way. We don't need a new vaccine. We need to use the vaccine we have.
Great, thank you. A follow-up to that, should people who have had COVID-19 get booster shots?
So I don't know if the term booster shot is appropriate here. People who have had COVID should get vaccinated because we know that you can be reinfected after natural COVID infection. And we know that those people who have had COVID and not been vaccinated are about 2.5 times more likely to be reinfected than people who have had COVID and have been vaccinated. So yes, we recommend that all people who have had COVID be vaccinated.
Great. And on a similar topic for you, Dr. Durbin, a question from Abby Isaacs with WMAR2 News in Baltimore. Do you expect Pfizer boosters to be approved Friday?
So, and I'm going to answer that in a little bit longer answer. So I do think that the FDA will approve, will say that these vaccines are safe and effective. So they will approve boosters, but it's important to note that the FDA's role is really to say, can we use this? Can we use this product? Or can we use this booster? It's the CDC who will decide whether or not they should be used. So even if FDA comes out and approves the use of boosters by saying they're safe and they do what they're supposed to do, the CDC will still need to review and approve the use of boosters to say that they're actually needed and who they are needed for. And it may be that they recommend it for different populations, the elderly, for instance, or people in nursing homes. We don't know. They're currently evaluating the data, and they will make a decision about whether or not the booster shot should be used and who should use them.
Great, thank you. Here are several questions from freelance reporter Valerie DeBenedette. Starting with you, Dr. Salmon, can you comment on the lawsuits against vaccine mandates? The Supreme Court ruled in favor of vaccine mandates in 1905.
So as the question points out, there's a long Supreme Court history of supporting vaccine mandates. First, in the 1905 Jacobson case, where the US Supreme Court's defined the role of the state's police power to require vaccines to protect the health of the population. There was a later Supreme Court ruling in 1922, Zuck versus King, where the Supreme Court said it was okay to link school requirements or to link vaccine requirements to school entry. So these, this is the foundation for public health law in this country. It's this Supreme Court defined role of the state to utilize their police powers to protect the health of the population. That's how we see tracing for STDs and inspections of restaurants for sanitary purposes. So there's a long history of this. Now, we're in some newer territory in terms of how such mandates are being applied. And for example, it may be very different for a state to require a vaccine than an employer. And the type of laws that would be applicable may vary. I do think that we are going to see more lawsuits. In fact, I just read that a federal judge put on hold a New York requirement for healthcare workers. And, I would anticipate that we're going to see lots of lawsuits and we'll see how they end up. But it's been clear that the US courts have consistently shown that there is an important state public health role in protecting the population, that vaccine mandates, at least under some circumstances, are a legitimate use of those state police powers. And I guess time will tell.
Great, thank you. And for you, Dr. Durbin, is there any more information on the risk of developing long COVID after a breakthrough infection? Is it likely?
So it's certainly not any more likely than it is with regular natural infection of COVID, and is probably less likely. Mostly I say that because the cases that we're seeing in breakthrough infections, we're not seeing as many of the severe or long-term symptoms that we saw in original natural infection of COVID. We know that if you do have a breakthrough infection, you tend to shed the virus or have the virus in your system for a shorter period of time than if you were not vaccinated. That's not to say that long-term COVID can't happen with breakthrough infections. We don't have a lot of data on that now, and we don't have any statistics really on the likelihood. But just knowing what we know about the differences in terms of symptom severity and shedding a virus in breakthrough infections, I would say that it can happen, but it's probably less common than with natural COVID infection in the unvaccinated.
Great, thank you. Here are two questions from Sarah Kim from WYPR, and I'd like both speakers to answer these questions. Start with you, Dr. Durbin. What do you think the state of Maryland needs to do to effectively tackle the Delta variant? What are your thoughts on its current approach?
So I will say my thoughts on the current approach is that Maryland is doing a very good job. If we look at the numbers of cases of COVID, we are at the bottom of the list in terms of numbers, meaning we have one of the lowest rates. I think I checked yesterday and it was about 18 cases per 100,000. So I think the state of Maryland is doing things right. We do have masks. We need to mask when we're indoors, even if we're vaccinated. We have relatively high vaccination rates, but we could do better. And that's what we need to do. We need, again, I sound like a broken record, but we need to get people who are unvaccinated vaccinated. That is the best thing that we can do. But overall, I think Maryland is doing a very good job.
Great, thank you. Dr. Selman on Maryland.
No, I mean, I agree with Dr. Durbin. I think that comparatively we're doing well, though there's still lots of room for improvement. I'll make a comment, a suggestion that's not specific to Maryland, but I think it could be helpful in Maryland, which is, we saw CDC loosen the restrictions on social distancing and masking for people who were vaccinated, yet we don't have a good way to implement that. And to me, that's a great opportunity to create incentives short of mandates. So for example, if you want to go to your local restaurant or bar, if you want to go see a concert or go to a sporting event, if you want to travel, it's safer for you and it's safer for other people in that environment if you're vaccinated. And what I think we need to do is encourage and see businesses require vaccination for their patrons and see states facilitate a way to verify vaccines in a way which is equitable and is unlikely to lead to fraud and abuse. And I think we could see a huge impact in vaccine acceptance that way.
And as a follow-up to that, for you, Dr. Durbin, and then Dr. Salmon, some jurisdictions have lower COVID rates than others right now. What are they doing right?
So I think I would have to go back and look at different things. There are just, as we see across the United States, we see across Maryland, there's different enforcement of different policies. There's local policies versus state policies. Some jurisdictions have higher vaccination rates, some require masking indoors. So I think it a lot depends on personal behavior as well as vaccination rates.
Great. And Dr. Salmon?
I agree. You know, a lot of it can be explained if you look demographically. We see higher and lower coverage by certain race and ethnicities and by political affiliation. And while I haven't mapped this in Maryland, we've certainly seen it nationally, and I'm sure it's true in Maryland too. We're not terribly homogeneous, and vaccine coverage is very different by these factors. And that helps tell us not just where we're going to see disease outbreaks, because we will see disease outbreaks where there's lower coverage, but also where we need to target our efforts. And some of this may be access issues. A lot of it is trust issues. And it's very different in an inner city African-American community in Maryland or anyplace else than it would be, for example, in a rural community that's politically affiliated and unlikely to vaccinate because they think, for example, the disease burden isn't real, or it's been overblown, or they're less trusting of the vaccine. So this is a time and a place where a one-size-fits-all approach is very unlikely to work.
Great. And here's a question from Tina Say at Science News Magazine for Dr. Durbin. One common reason given for resisting vaccination is that we, in quotes, we don't know about the side effects. Can you address what we do know about the side effects, including blood clots, cardiac problems, and other serious problems?
Certainly. So I just want to start by saying we have more safety data on these vaccines probably than any other vaccine currently used here or anywhere. We have hundreds of millions of people who have received these vaccines. Here in the United States, we have several different means, and Dr. Salmon can speak to this as well, on measuring vaccine safety. We have different systems. We have the Vaccine Adverse Event Reporting System, which reports directly to CDC and FDA. We have a safety data link system, which is comprised of different medical systems. We have very, very good safety data, and we can say that these vaccines are incredibly safe. There is a very, very small risk, and when I say small, I mean I'm talking about 1 to 2 per 100,000 risks of certain blood clots with the adenovector-based vaccine, the J&J vaccine. There is a very, very small risk, I think it's 5 in 100,000 risk of anaphylaxis, which is a severe allergic reaction to the mRNA vaccines. But we have not seen we haven't seen serious side effects from these vaccines. People do get myalgias, muscle aches, low-grade fever following vaccination, particularly the second dose with the mRNA vaccine. But we have a tremendous amount of safety data, and I will say that the CDC investigates serious adverse events if they think there is a signal. They investigate those cases. They try to determine if there is a link between the vaccine and the serious adverse event. But by and large, I will say we have more safety data on these vaccines, and the safety has really been there's been a tremendous effort to ensure that the safety issues around these vaccines are studied, are documented, and are relayed to the public.
Thank you so much. Here is a question for Dr. Salmon from Rob Flax at WMDT, Salisbury, Maryland. How does flu season play into what we can expect? And are the experts predicting a fall-winter surge?
Yeah, you know, thanks for the question. We published a commentary in JAMA about a year ago, warning of the dual pandemics of COVID and flu. And, you know, the big risk here is that our healthcare system has limited capacity. And in the winter, it usually hits that capacity in many places absent COVID, and flu is often a big contributor. And if we see COVID hitting capacity in healthcare systems, the dual whammy could be a lot. Now, last year we saw a very mild flu season, and a lot of that was probably because people had changed their behavior. And we saw a lot of social distancing and a lot of mask wearing. And, you know, that really helps prevent the spread of all sorts of infectious diseases, maybe intended for COVID, but also for flu. So, you know, I'll say this, flu is a very hard disease to predict. It's what people would call a sloppy replicator. In other words, it changes on its own in ways that make it difficult to predict. And over the years, in talking with some of the world's flu vaccine experts and flu experts, they're careful not to try to predict the flu because it's hard to do. And there are people who have tried to predict it and often doesn't go well. So I'm not going to try to tell you what will happen in the fall. But what I will say is that we have really good vaccines for COVID. We have reasonably good vaccines for flu. We should use them both as widely as possible and hope that we don't see co-pandemics that make things worse.
Great, thank you. Here's the next question from Daniel Chang with Miami Herald for Dr. Durbin. Does infection and recovery provide as good or better protection against reinfection than vaccination alone?
So that really depends on the severity of your infection. So we know that there are people who have very mild natural infections and their immunity may wane more quickly. What we do know, and I think I mentioned this a little bit earlier, we do know that if you have had a natural infection and you do not get vaccinated, you're about 2.5 times more likely to be reinfected with COVID than if you've had a previous infection and are vaccinated. So yes, natural immunity generally does provide good protection, but the price you pay may be a very severe infection. And what vaccination does is provide very good immunity without the severity of illness that natural infection does. And we know that vaccination on top of natural infection provides excellent immunity, probably better than natural infection or vaccination itself.
Thank you. Here's another question for you, Dr. Durbin, from Denise Rowland of the Wall Street Journal. The important question of vaccine equity aside, is it reasonable to provide boosters as a kind of insurance policy going into the winter, as many wealthy countries are doing?
So I look at it this way, and first of all, I want to say I don't think we can put equity issues aside, particularly during a global pandemic, because we will not stop COVID from coming into the United States unless we stop COVID around the world. That being said, I will say that, the purpose of vaccines is not to prevent every single symptom. And I think, right now, the indication is that we don't need additional boosters. We don't need an additional shot. Will it improve your immune response? Will you see higher titers of antibodies? Yes. Do the safety data look good? Yes. Does that mean that we need boosters? No, and we shouldn't be giving a valuable resource just because we can. It really needs to be indicated, I think, by the epidemiology of the disease and of the illness. So I think for the vast majority of people in America, a booster dose is not indicated. That doesn't mean that we won't see, as more data come in, that there may be populations within the United States, particularly the elderly, for instance, or people in long-term care facilities, people who were hardest hit by COVID at the beginning of the pandemic, who may require a booster. But I think we really need to see that, and the decision to give boosters need to be data-driven.
Thank you so much. And here's a question from Rachel Nania at AARP for Dr. Salmon. I'm wondering if you could talk about the Mu variant, which we've been hearing more and more about. What is it about this variant that may be cause for concern?
Yeah, Anna's probably better suited than I to talk about the variants.
Okay, go ahead, right. Go ahead,
I'll take this. So we're talking about the Mu variant, which is circulating through Colombia. I think what has some people concerned and why it's becoming a variant of interest or concern is because the mutations in that appear to affect how well antibodies can bind and neutralize the virus. And we saw the same effect with the Delta variant early on. Now, what I will say is we know that even with the Delta variant, antibodies didn't bind as well, but the protection induced by the vaccine against severe disease and hospitalization was 95 to 100%. So you have more to your immune system than just antibodies. People, again, are concerned because Mu took over in Colombia, and there's concern, could it come in and sort of replace the Delta variant? There's a lot of factors that would have to happen for that to be the case. For instance, Delta, we know, is incredibly infectious and highly transmissible. These viruses are sort of in a fight to the finish. The fittest virus is the one that survives. And Delta overtook the Alpha variant. Whether or not the Mu variant could compete with Delta, we just don't know. But I am confident that the vaccines would do induce very high protection against even the Mu variant. But we have to wait and see. We're getting new data every day. What I say today could be different tomorrow. I do want to have that caveat out there. But for today, I'm confident that the vaccines would induce high protection against even Mu.
Okay, last question. This is for you, Dr. Durbin, from Kate Amara from WBAL TV. I get this question daily from people aged 85 and older and frontline healthcare workers, many of whom have been fully vaccinated for 9 months now. As we begin to get our yearly flu shots again, at what point does the booster shot or additional dose that all the experts are discussing right now become my yearly shot?
That's really a great question. And I think I will say that the coronaviruses are not quite the same as the flu viruses. The flu viruses change so much every year, and the vaccines that we currently have are far less potent than the vaccines that we have against coronavirus. And those are the two factors that are requiring yearly flu vaccination. I think we will require boosters or more than just our primary series of vaccination against COVID if we are unable to control this pandemic. If we continue to see surges that are requiring hospitalization and in really taxing healthcare systems, I think we're going to see that we need possibly booster doses. Whether it would be every year, every 2 years, it's unclear. But if we can control this COVID with vaccination and with, unfortunately, natural infection, such that we're no longer seeing the severity of disease, we may not need really booster shots every year. But a lot of that is going to depend on the epidemiology of the pandemic.
Thank you to Dr. Durbin and Dr. Salmon for your presentations and insightful answers. We will email the links to the resources mentioned today and share it in the chat. And with that, I'd like to say thank you again to everyone for joining us today.